Hello everyone, welcome to The Voice of Nursing. My name's Adrian Tracy, I'm the CEO of ICG Medical. We're very lucky to be joined by Dionne today. Dionne, welcome to The Voice of Nursing.
Thank you.
Tell us a little bit how you got into nursing.
How did I get into nursing? I got into nursing after sort of thinking about what I wanted to do. As a child, I wanted to either be a nurse, a teacher, a social worker. At one point, I wanted to be a nun, and when I realized none of those options were viable, I got into nurse. I signed up to do nursing. I left a job that was paying me more than it paid me to be a nurse because I was fascinated by nursing, and the rest, as they say, is history. Loved it. Loved my time there. Loved learning. I loved spending time with my colleagues. I'm still the vice president actually of my batch, believe it or not, as that my song. I love nursing. I love everything about it. It just flows here.
So how did you made that decision, you were in a job, so you went to as a mature student?
Yeah, well, mature, I was 24-ish.
That's pretty mature.
Yes, compared to everyone else who was coming out of school. So that was different because obviously we had the equivalent of a bursary, but it obviously meant that I had to give up a salary to do it. I had to get back into education and also get used to being in a big class because our batches were like 60 people. I know. When I think about it now, it's crazy. And I think in the first year, some of our colleagues dropped out because they failed out, and that was really traumatic for me. But I love nursing. I've always been active. I've always been, as a student, I was active in the Nursing Association. As a newly qualified member, I trained in Trinidad and Tobago, I should say, not in England, and then went with a friend who was thinking of going to England, had no interest whatsoever. I came to England and the friend didn't. Yeah. So I came for a year, 21 years ago.
And who did you join with first?
I started in Eastbourne, East Sussex Healthcare Trust, which is where I still live. I started and worked across the trust in different fields. So I'm a medical nurse by background. Diabetes and endocrinology is my specialty. Worked in different levels. Worked as a ward manager. But got my first sister's job after challenging the system because I came here as what was called a top band D nurse, and when I went for an E grade, band F grade nurse, which is now called band 6. Got called the day of the interview and was told that even if I was successful, I wouldn't get a job because I had been in the country 13 months at a time. And I said, well, I'll see you in 20 minutes because I have an interview. Went to the interview and did really well. And I had some really good people who petitioned on my behalf. So the trust then changed the way they did things in terms of recruitment. It didn't just say NHS experience, it said equivalent experience. And that's, I think, some of the challenges sometimes when you're a nurse who trained overseas or trained overboard. You sometimes, have to fight for things like this, but it's been a good journey generally.
Mm-hmm. So in Eastbourne, where did you go after that?
For 15 years, because obviously I couldn't leave. So I started as a staff nurse, then was then an E-grade nurse, became a band 6 sister, and then did a ward manager role in that ward, which I loved for 5 years. It's the hardest job in the universe. But it's such a rich job. I loved it. I love my time there. I love the time I spent with people. Love my experiences with diabetes and endocrinology. We set up endocrine unit. We set up the service for the first time in the trust. Then went, of course, to Hastings to be a site manager. You have to love site managers. I don't know why anyone would choose to do that job for more than any time. I did it for 13 months because obviously
Why is that?
Because it's very demanding and no one loves you.
Okay.
Basically. But it's such a rich job. It gives you such a really good output. You learn so much operationally. You learn about how the organization works. I think when you tend to be in a ward or in a unit, you only focus on that ward and how that works. As a site manager, you have to understand how the hospital works and how the health economy works. So that was really useful information for me. And obviously living in Eastbourne and working in Hastings, looking at the difference, because Hastings probably still is and was then considered quite deprived. So you looked at the difference in care. My very first day on the job, I'll never forget, somebody came in and OD'd. And that person was the same age as my brother at the time, and that was really traumatic. And site managers deal with things like this day in, day out, sometimes without an outlet. But it was a job I laughed a lot. I walked around the hospital, which is good. I love walking. You meet people, varied people, and I've met some really good friends doing that job. So that was fabulous. Then I decided to become a practice development nurse. So I worked in corporate nursing. That was fab. Worked on a project on documentation and record keeping. I guess if you look at the research across the years, there's always reams and documentation and how nurses document or don't document. Worked with a fab professor, Dionne, so who had a joint role with my trust and Canterbury Christchurch University. Did some work on documentation, record keeping, mental capacity, writing up resources for the hospital. Presented the first time at the conference, which was amazing, and did some writing in terms of an article for a magazine. So that was great, and I loved that, but that was coming to an end because, always with these corporate roles, people are not sure whether they wanted to carry on or not. I decided, for some random reason, I think I'll go and work in London, and everyone thought I was mad because I was planning to commute. So I decided to go to Bath Health, applied for a ward manager's role there, in older people's services. They had just moved across from the old London to the big old blue building. We were on the 14th floor, amazing views. Unfortunately for me, I started on the day they were having a massive restructure. How not to start a job. So that was a bit of a challenging time, but it was also really good. Older people services is not my background, but I have a passion for it because both my grandmothers were in their 90s when they died, and they died how I think everyone should be able to die if they're allowed to. They died with the people they loved around them. They died with dignity, didn't have continent pads on them. They were able to make choices about what they wanted to eat and do, and they stayed in their homes as long as they possibly could. So that drove my passion for the people's services. East London is a rich mix. You've got a large Muslim population, Asian population. You've also got a large Jewish population. And you've got a lot of people who still remember the war. So one of my passions with the war that I worked on is this big gold glass window, and you can see East London, different aspects of it. So I love taking patients to that window, and they will tell you about walking to the station during the war. I get emotional every time I think about that, actually. They will tell you about places that were there and not there, and I just loved being able to do that. I just feel, even though I live in Eastbourne, and there's something about East London that makes me smile, I just loved it. So I did that for 20 months and then went to Newham University Hospital, which is still part of Bath Health, as a senior nurse for older people and stroke services. And I laughed a lot at that time, but I've cried a lot because it's a hard old job. And I feel passionately about Newham. Newham is one of the most deprived boroughs in London. And I feel passionately about the care that the patients receive and that staff receive and the people in that area. Because very often, if you live in a deprived part of the world and English is not your first language, you don't get a voice. So I love that aspect of Newham. Some things troubled me. It troubled me that if I walk from the hospital to all the way along the street away, you got 15 chicken and chip shops. Very few places with fruits and vegetables. I just love the diversity. So there are people from all over the world, and our staff represent that as well. Not necessarily at higher levels, but I just love that aspect of it. But it's so hard sometimes hearing some of the stories and seeing the outcomes of people, younger people with strokes, that just wrecks their future, really, if I'm honest. Did that for 2.5 years. Spent some time in corporate nursing, writing policies and supporting some work around workforce development. So did a review of all clinical nurse specialists. An amazing bunch of people who don't get credit at all. And actually the evidence shows that clinical nurse specialists, they actually provide better outcomes sometimes than doctors, and we don't talk about that. We've got nurses making a huge difference in the life of people, particularly in cancer care. And their voices are not heard a lot. And I think it's time for us to do a bit more to recognize the amazing work that they do. Off soapbox. And did some work around enhanced care, and now I'm working in the Education Academy doing an action research project looking at the role of nursing associates and how that fits into the nursing establishment. So that's my journey.
Very good. Tell us a bit about the nursing associate work you're doing. It's obviously quite a hot topic.
Well, it is. So I started that this year actually. This role was introduced in 2017, and yeah, some people talk about it's like the enrolled nurses, it's dilution of nursing. It's quite topical. You only have to go on any Facebook forum or any of the old nursing forums to see the arguments. I think for me, the role allows opportunity for people. There's a nursing associate who I work with, she was a healthcare assistant for 20 years. And so she's now in a nursing associate role, and the thing that resonates with me is that every time I see her, she has a smile, a beautiful smile. You know, she's so proud to be able to do something different, to have the opportunity. Most of the nursing associates who work at Night Trust will want to go on to do the nurse training. So it will take them 4 years, but they will work and have a nursing degree, but they will come out of that without having any debt. And if you're an older person, if you've got responsibility, if you're a single mother, you can't take a hit and spend $50,000 to go to university. You just can't do it. You can't do it and live. So I think it offers a route. I do understand the need for people to be concerned about dilution, but we also, I think of it as a pathway for people who are care assistants. I wish we think about the associate practitioners, because they've been languishing for years and they've not been registered, which needs to be sorted, and understand that might be reviewed. And we just have to see how it works, and no one is certain. So people on the boards are not sure where the role fits and where it exists. Nursing associates are not sure themselves. Healthcare assistants, most of the nursing associates who were recruited came from that group, they're not sure. So it's an interesting journey to see.
I was going to say, what are the boundaries for each one? Where do you sort of start as a healthcare assistant and stop? Where does an associate nurse start and stop? And then when does a nurse start and stop? You know, what are the left and right boundaries, I suppose? And
that's what we're trying to figure out. But I think the main thing to know about the difference between a nursing associate and a registered nurse, the registered nurse can assess care. So first level assessments is the registered nurse. It wouldn't be done by a nursing associate. Registered nurses lead care. So unlike the enrolled nurses of the old days, nursing associates won't be managing wards. They will support nursing assistants. They can't do controlled drugs at the moment. So there are limits. I think that's the thing that people are curious about, and that's the thing we have to manage, because the Care Quality Commission is quite clear that they want us to be able to make sure we've done assessments about how these roles are placed and how they function. We also have to acknowledge we've got 42,000 nursing vacancies. So, getting on my soapbox.
No. Well, that's only getting higher with the nurses retiring.
It is, and quite a lot of nurses are retiring. Let's not talk about the B word. We may lose some nurses.
Yeah, we said we'd fine you if you did Brexit. We're not doing too much Brexit talk today.
No, we're not. And also, it's not as an attractive career for people. If you're going to pay to go to university, sometimes people think, is it worth doing it? I will argue that it is. The NHS has always been dependent on overseas nurses. So when people say we need to go our own, yes, we do, but since 1948 we haven't. Since 1948, people from my aunt's generation came here and worked, treated terribly, but they came here and worked and supported and made the NHS a reality. And they still work here working. So we do need to look at other avenues, and we do need to recruit local nurses, but we also have to keep it real. We have to make it attractive.
So what are the sort of key things coming out? Because the project you're doing is a nursing workforce remodelling research project.
Yeah, it's a very long
name,
yeah.
So I make sure I get it right.
Yes.
What are the sort of 3 things that are coming out of that?
Well, we're at the beginning of the journey, to be honest. So we've been doing a literature review, because obviously we haven't had enrolled nurses for a long time.
For anyone who doesn't know what an enrolled nurse is.
Yeah, so an enrolled nurse,
what used to be, Jose?
What used to be, and still have them in Australia and New Zealand, it used to be what we call a second level nurse. So they were nurses who will only go to certain levels within the nursing family. It tended to be mature people as well, and again, a lot of times in the old days when people from out of Europe came to do their nurse training, a lot of them were directed to do their enrolled nurse rather than the registered nurse pathway. Fortunately for my aunt, she came here as a registered nurse. So for some people, it's a part of the nursing family to free the registered nurse to do different things, and that's how the role is trying to work itself out. I think there's a lot of cynicism, which I understand, because I guess for some people they're thinking that actually if we have this rule we can remove nursing posts, and that's sometimes I think where the challenges lie. It's early days, so we're still trying to see where's the best place for these roles to work. Acute nursing, or is it better in older people's services? We've got people working in theatres, as scrub nursing associates. So it's early days to try to figure out where the role fits, because just typical, we create roles and we don't necessarily think it through. So we're trying to see what that looks like and how does that role fit into the establishment. So it's early days, and I know I haven't given you a lot of information, but there isn't a lot of information to give.
What do you think, if you look in your crystal ball, 2-3 years time, where do you think that role will end up?
I think it would be a pathway for people to do the nurse training. So we know that 60% of people who've done the nursing associate training would like to become registered nurses. So I think that's where a lot of it will go. I think some people will be quite happy to remain in nursing associate role, and that's where we have to look to see how that fits and how that supports registered nurses, because the evidence still tells us that actually the more registered nurses you have, the better the outcome in terms of that. So we can't ignore that, but it's trying to have a fit. It also is a pathway for healthcare assistants, because a lot of times if healthcare assistants don't want to do their training, there isn't a pathway for them in terms of career-wise, and we have to think of different routes of getting people into nursing, because I think it will be dramatic. I think if we don't, we probably have a bit of a crisis in a few years' time when people like me retire.
Yeah, I think one of our cancer nurses was on before, and he was saying that I think over the next 5 to 10 years, 35% of all specialist nurses are retiring. Yeah. And they're, that's not training. That's a hard gap to fill. It's not like you can bring people in.
You can't. There's no pathway. There's no pathway to prepare people to look at. I think what we need to look at a bit better in nursing and in healthcare really is succession planning. So what training posts do we have to support specialist nurses? What's the plan? What's going to make older people's nursing, mental health nursing and other specialties attracted to people? Because everyone wants to be an ICU and an ED nurse, but actually being a nurse in older people's services is quite complex, and it takes skill and specialty, and we sometimes don't think about it.
Older people tend to have more issues these days, don't they? It's just like one issue. It's 2, 3, 4, and with the way the drugs are developing and things, like people are staying alive longer, aren't they? And we have that older population in Western Europe as well.
Yes, and that older population paved the way for things that are easy for a lot of us. So I think it's really important that we ensure that we have care that's dignified for that population, and they sometimes get forgotten. ED, ITU, so there's a bit more sexy and older people's services, isn't it? And obviously I live in Eastbourne. It's also higher older population, and I see, when I'm walking around the seafront, I see the older population bustling past me. So people make assumptions of an older person as someone who's frail, who can't think and who can't make decisions.
No, I think quite the opposite. They tend to be a lot more active these days, don't they? They're not kind of your grandfather, your grandmother's generation where you think older people are around, travelling, having fun.
My dad leaves a gym workout, he does my parents walk around the stadium every day in Trinidad, and my dad, there's a little gym, I call it the old boys gym, and they do their workout. And 20 or 30 years ago, people in generation Trinidad and Tobago probably not think about that.
No.
So it's changing, and we have to change, and care has to change to meet that. Also, when I did my training 1,000 years ago, we were meant to be training for 2020, and most of the care would be delivered in the community and not in the hospital. We're in 2019 now, we've not realized that dream.
No, not yet.
We have to start thinking of doing different ways. So I think planners need to not think that actually we'll have less hospital beds, but we need to have a plan in place for community care to be more viable.
Yeah, you need the social care, don't you? The budget matching up to the acute budget.
You do, and you also need to have a plan for care in the community. We can't just send people into the community when we know there are lots of vacancies in community nursing.
Yeah,
and we haven't thought of different ways around it.
And I think the wellness aspect as well, trying to make sure we keep people out of hospitals is another big thing.
It is, but it requires people working there. If we're training people to only work in hospitals, how are we going to meet that need? 2020 is next year, and it's not going to happen. It's also the year of the nurse, which is great. Yeah. And for me, I'll probably get into a bit of trouble for them. I'm going to say it anyhow. For me, I think I regretted the one thing my union and professional body did was coming out of the International College of Nursing. I think now more than ever we have so countless nurses. We have so many issues nursing that we could deal with globally, that we can address globally. And I think it's time for us to reach out rather than reach in. And I think we come into a point where we seem to do a lot of reaching in, so we're not learning from other people. And I would like to see a bit more of that as a nurse.
What do you mean, from like an innovation standpoint or from a staffing standpoint?
Innovations, dealing with issues around staffing, dealing with how nurses are recognized. We can learn from a lot of other bodies, and I suspect we still do because we've got an international committee. But I do wonder if now is the time for us to rethink how we learn, especially with, events that are coming up. What's going to be the reach into those committees after? I'm not going to say the word. I'm not. Sorry.
And obviously one of the things you were talking about, the education of nurses, obviously you've got your degrees, your master's degree and your bachelor's. Some schools have thought, like, you'd never ask a doctor not to have a degree, so why would we ask a nurse to have a degree? What are your thoughts about that? Because obviously you're kind of working both ends of the spectrum there.
Yeah, I am, and I think people always have the perception that if you're a nurse with a degree that you're too posh to wash or whatever that means, and it just tells me a lot about what the public think nurses do. Nurses, they think, they lead, they innovate. It's not just about washes, which is important. As in any role as a senior nurse, I still did clinical care, still work with patients. That's important. I don't believe we can go back to the good old days that people would like to have, and everyone thinks that in their days things were better. It's not. Things move on, people move on, and I think it's not about beating up people who don't have degrees, because yes, you can have a certain level of thinking without a degree, but having a degree and a master's is also about being able to analyze and being able to use that information in care, keeping up. I got really frustrated sometimes when people said to me, in my days and I trained at this time and I didn't have a degree, but this person, they've not read anything recent about what's happening in care, they're not up to date with the recent thoughts, they don't know what the policies are, and how could you provide care in that context when you're dealing with people like my 7-year-old goddaughter who can navigate the internet like nothing, and who wants to be a YouTube vlogger? That generation is thinking differently. So how dare we not keep up? You're dealing with a generation of patients and clients who Google. Yeah. And who can reach the world a lot more than in our days. So you have to have that context. You have to be at a point where you're able to read and understand the latest policies, because then how could you support care moving into that direction?
I was going to ask you, how do you approach patients then if they've Googled all their symptoms and Googled what they think the answers are, and how do you manage patients like that?
It's good. I think I will always allow that, and I always like people to talk through what they found, and then we take it into context, because not everything on the internet is great. But the thing about care, and I haven't worked in diabetes where people are experts in their conditions, you have to bring all of that to the table. So you have to bring what the person is saying and feeling, and you have to work that into a plan. It can't be the old days of nurses and doctors doing to people. It's about including people in their care and taking them through the information that they may have found.
This is the patient-centered approach.
Yes, and being respectful, really. Yeah. Because if you have when I worked in diabetes, you had young people with diabetes, and they've got their phones and their tablets and whatnot, and they know what they want to do, and they know their rights, and they know what's happening because they've Googled the latest. So it's about being able to match that as a nurse or a healthcare professional.
What do are you seeing much change in the diabetes market? Because that seems to keep coming up. We see more people with it. People are getting bigger.
Yeah, people
and
bigger.
Diabetes is becoming a bigger issue.
More people. I don't work in diabetes care anymore, but there are new changes. There are new treatments all the time. It's getting excited. People I remember when, in the old days, when insulin pumps used to be this big old thing. Now you've got smaller pumps for people with type 1 diabetes in particular. You've got different medication and insulin, and people directly want to own their care. So you have to be mindful for that, because we've got an implosion in diabetes. A lot more of the population got diabetes and will have. There are people walking around now who don't know that they've got diabetes. So we have to be pragmatic, and it's challenging if you're an older person. If you're 80 and you're diagnosed for the first time, how are you going to manage that for someone who doesn't want to follow a strict diet and a strict plan?
Especially if you've got 80 years of living your own way.
Living your own way, living that way. So that's why we need to be a bit mindful of that. And the thing I would like to, my branch of the RCN, we've got a lot of colleagues who are very politically minded, and we have to acknowledge that aspect of it as well. So I love the fact that people think that nurses are not political, which is capital P, but we need to be political, which is common P, because we need to speak up on behalf of our patients. We need to have a voice. It frustrates me that we're the biggest population in the healthcare services, but we have the smallest voice. And I believe in that thing that we need to roar. We need to roar a bit more. We need to speak up a bit more. And we need to have our voices heard.
Well, hopefully we're doing that today.
I'm so back, yeah.
Tell us about the hashtag NHS 1,000 Miles campaign.
Okay. So that started. So last year, Kath Evans, who's fab, she's now at Bad Health, wanted to recognise that the NHS was going to be 70 and wanted some people to do 1,000 miles that year to recognise the NHS. So I signed up for it, because I'm always up for a challenge. So we did that. We did over 1,000 miles, and we're going to carry on this year. And it's a great way for people to keep track of their health and to be mindful of being more active. Every Sunday we clock in either on Twitter and Facebook about how many miles we've done for the week, and where we are in terms of miles each month. This last 2 weeks has been a bit slow for me, because I had a little bit of an injury, but I'm going to keep going, because another organisation that we support, Cavell Nurses Trust, we normally do something every year. So some of us have signed up to climb Snowdown. I don't know if I'll make it, but I'm up for it. I was up for a challenge.
Tell us a bit about the Cavell Trust. We know it, but it does some great work.
Amazing trust, doing great work with nurses, midwives and healthcare support workers. We hear all the great stuff about nursing and the view that nurses make all this money. We don't hear about the person who has cancer and has to stop working and then require funding, because after 6 months or so, depending on how long you've worked, your salary stops. They've been doing some amazing work to support nurses, support nurses who've had major issues with their health to get back into work. So it might be buying a wheelchair. It might be providing financial support for someone who's undergoing cancer or can't work. They're amazing trusts. They're very small. They were named after one of my nursing heroes, Edith Cavell, who died in the war because she stood for her values. And they do amazing work throughout the UK, actually.
It's basically a charity focused on nurses in hardship, isn't it?
Charity, nurses, hardship. But it's not just about hardship. They also do things about celebrating the nursing voice. And it's great. I support them, because the RSN also has a foundation, but I support the work that they do in terms of funding. So last year, I believe we raised £30,000 in all in October. There's a focus in May for baking, which I'm going to not participate, because baking skills are non-existent.
Buy one from Tesco's and stick it on a plate.
That's normally my version. So it's great organising. I like to know that organisations like this get a voice. Having a voice is a big deal for me, which is why I don't shut up. But
nothing wrong with that. And what advice would you have given yourself going into nursing if you met your younger self now? Is there anything you would have given advice or anything you'd have changed?
I think be braver. I think there are a lot of things I could have been braver about. I could have tried different things with different specialties that I wanted to explore, but I didn't. I think even now, in terms of thinking about what I want to do next, I could be braver. So I would have said that to my younger self: be braver.
And what sort of trends do you see coming up over the next year or two?
So I like to believe that when I trained in Trinidad all these years ago, we talked about nursing 2020 and about nursing being not mainly in the hospital. I would like to hope that will happen in the future. I like to hope there are different opportunities for nurses who want careers. At the moment, if you're at this level that I'm at and you want to go into academia, you sometimes have to take a step back. I would like to think that we'll be able to finalize that more to allow people different opportunities.
What do you mean? Is in grants and things like that, so they have the opportunity?
If you want to follow research, sorry, stop waffling. If you want to follow being in the university, sometimes you have to take a big financial hit. I'm being honest, and you have to take a step back, and it would be nice to have that opportunity. That it's okay to think about academics and be in a hospital. It's also okay to look at other ways of where we nurse. I would like to see more independent nurses. So people who, sometimes we have a couple of, I think in Kent, nurses leading practice, general practice. I like to see a bit more of that.
Oh, surgical nurses and things like that as well?
Surgical or practice nurses. I don't think they get as much acknowledgement. We always talk about the shortage of GPs, and please don't shoot me GPs, but actually, how could we utilize our practice nurses more?
Yeah, or the advanced nurse practitioners. There's, lots to talk for them at the moment.
Absolutely.
Helping run practice, because I think we're 5,000 GPs short as well.
Yes, and I believe, and it's not to discredit the general practitioners, but practice nurses make a huge impact, and there's no cost for them, and that's not always acknowledged in funding. So basically, I like nursing to rule the world.
But giving it a good go. One thing we talk about is burnout, and also nurses are great looking after people, we're looking after each other. Do you see much of that, or did you come across much of that?
I see a lot, and I've seen it in myself as well. I've come a lot of times, I think, in my career being close to burnout, and you're right, we're very good at fixing and looking after others. We're not necessarily good at looking after ourselves, and I think that's something that we need to encourage more. This business of nurses not taking breaks and can't take breaks.
Can't take breaks, can't go to the toilet, can't get any lunch. I think it's almost jokey about it, but it's not good.
It's not good. And in terms of working, I think when you look at the staff survey, the number of people who are working beyond their hours and not being paid for it, we need to really take the advice that we give to our patients about looking after ourselves. And I think we need to recognize it and be mindful of it. My latest passion at the moment is, I think in healthcare we don't spend enough time talking about menopause. Nursing, 71% of the nursing population, or probably more than that actually, are women. And we have quite a large number of those are the age of menopause. And I know men get really squeamish when the talk is there, but what we're doing to make those environments better for people to work in so they can continue their career.
And obviously you climbing Snowdonia, so you're doing a bit of training for that. What else are you doing outside of work, if you have the time?
Well, at the time I'm an Oxfam volunteer.
Okay.
I have a passion for Oxfam and the work that they do. So on there are Saturdays I spend time in there working on the till, chatting mainly, tidying up, just putting stuff out. I love to be able to just go in and not have to worry about being in charge, just getting involved, clearing stuff. Please don't donate your taxi stuff to the charity shops, and just speaking to people is a great way of getting to know people. I do children's work in church and youth work, let me please, because I think it's really important. I don't have children myself, but I think it's really important to support younger people to get there, and also to support parents, because if you've got a 1-year-old, let's say, and you want to sit down in church and listen to the sermon or just have a break, it's nice to know that someone will take them away for an hour and a half and you can spend that time. So those are some of the things I do. I like to do a little walking. I live in Eastbourne, so I do a little walking on the seafront. Sometimes I forget that I have limits, so I might go off walking and then get somewhere and realize I've got no money or no food and I have to get but it's great. I just like spending time with friends as well and people, and I think I've had some incidents over my career as a nurse that made me realize how important relationships are, how good it is to spend time with people, how good it is to travel and see places. and see a bit more of the UK beyond the M25 really. So.
And are there any nurses in your career that inspired you?
Oh, there are loads. First of all, it would be my aunt, who came here in 61, and she was a cardiothoracic nurse. She still thinks I can't tell anything because I'm not the boss of her. Caroline Alexander, who's the director, chief nurse at Bart's Health, and her background was she's as an older people's nurse. She inspires me. She's one of the people who have done a lot, but they're very quiet about it, and who embodies compassion. I'm going to name check my manager again, Debbie Juraz. She's quiet, she's laid back, doesn't always get a lot of credit, but she knows, she's got such a wealth of knowledge, it's amazing. I've spoken about Jan Dewin before. I worked with her, and her knowledge and her passion for research and her passion for professional practice development amazes me. I talked about Edith Cavell. I recently found out about Catherine Pine, who actually looked after the suffragettes when they came out of prison. And I work where I work is close to St. Bartholomew's now, and there's a museum there I'm dying to get to. There's so many nurses that inspire me. Mary Seacole, Florence Nightingale, of course. And I'll have to name check one of my nursing instructors in Trinidad and Tobago, Mrs. Foster. She was awesome. She gave us the passion, and she made us realize that everything you did as a nurse is important. I remember running to the sluice to hide from her. And she would come in there and talk to us about what we were doing and how that made a difference. And that was something that was relevant to me. And we also had an instructor by the name of Russell Salcedo. And he is an inspiration because he always said to me about, you always teach people. It's one of the ways of keeping what you do. Always teach people. You share your knowledge. You never keep it. And hopefully it's something that I try to do today.
Sounds like it. Is there any message you'd like to give our nurses or healthcare assistants or doctors watching this?
Don't keep quiet. Find your voice. Particularly nurses. You have a voice. You have a role. Please find your voice and speak up. Be proud of what you are. You're not second class. You're doing an amazing job. Keep doing it.
Thank you, Dionne.
Thank you.
Thank you very much for the voice of nursing. Thank you to our nurses, doctors, healthcare assistants, and allied health professionals that look after us all. We'll catch you again soon.